Assalamu alaikum. Today we are discussing right-sided pyeloplasty for a lady who is around 45 years of age. She presented with a lumbar pain which was dull and was occasional. Upon doing a routine sonography, she revealed to have a right-sided moderate hydronephrosis, and the ureter was not dilated. So a CT urogram was performed, which confirmed all those findings, and there was an abrupt cutoff at the level of PUJ, and a DTPA scan was performed, which confirmed the kidney to be hydronephrotic as well as obstructed at the level of PUJ. We have mobilized this colon. We have lifted the liver, and now we have identified the ureter, and we dissected over the ureter towards the hilum, and we found this huge dilated extrarenal baggy pelvis. We were expecting crossing vessels because in 30 to 40% of the adult cases where there is a PUJ obstruction, there is a likelihood of finding the lower portal vessels, for which the misnomer is aberrant vessel. Actually, it is not an aberrant vessel, but there is just an early division of the renal artery into anterior and posterior branches, and the branches or the segment that comes to the lower pole crosses the PUJ if it is divided early. So that leads to PUJ obstruction, but here it was not the case. Here you see that the ureter and pelvis have been dissected enough. The segment, abnormal segment with obstruction, has been identified. The ureter below the pathological segment is quite healthy and has a good lumen, and now the spatulation is performed. Spatulation must be enough to allow an anastomosis. Cutting here, the pelvis, usually redundoplasty is not required in all cases. However, here the pelvis was quite large, so we went for a little bit extra resection. Care must be taken not to overstretch the pelvis, because if you overstretch the pelvis and then you start cutting, there is a tendency that after the cutting is performed and you leave the stretch on the pelvis, so the pelvis will contract, and usually one finds that over resection has been performed, and the calyces may be jeopardized in that case after the repair. Here you can see the end of the ureter is quite healthy. It is vascular, and now you will see that there is no tension. A little bit of fat is intervening at the place of at the site of anastomosis. That's why it seems to be a little under tension. However, it is not under tension at all. So all the principles are being followed. As I mentioned in my other video of pyeloplasty, it is worth mentioning here again that the lower portion of the pelvis must not be resected at all, which is along the lower pole, because if you cut it, then it is not possible to bring the ureter and the pelvis together without tension. And this tension, of course, number one, will lead to ischemia of the anastomosis segment, number one, and number two, if it is under tension and you have resected extra portion of the pelvis, then after retraction, the anastomotic portion will get attached to the lower pole of the kidney, which will lead to failure of the procedure and reconstruction. Here you can see that I'm holding this ureter and the pelvis with with the Maryland's forceps, which is actually a traumatic forceps. However, it is worth mentioning here that I'm holding them just the way that the cat is holding her kittens from the neck while transporting them from here to there. She is holding the kittens from the neck with her sharp teeth, but the hold is strong enough to carry the kitten, but it is at the same time soft enough not to cause any injury to the neck of the kitten. Same is the case here. So you hold it soft enough not to cause any crush injury, and also strong enough to take a stitch. And another important thing is that the initial 1 or 2 stitches at the corner are extremely important, and crush injury at that level must be avoided. After that, after 3 to 4 stitches along that line, the borders really don't matter, because the rest of the anastomotic areas are normal and healthy and vascular. And the second important thing is the areas which are stitched are going to get devascularized anyways, get the fibrosis anyways. So the borders are not really important, especially after initial 2 or 3 stitches at the corner. So the posterior layer is about to get completed, and then next what we are going to do is that we will take a stitch at the corner for the anterior wall, and then we will place a DG stent. So it is worth mentioning here again the basic steps of pyeloplasty. Number 1, excision of the diseased segment. Number 2, maintaining the vascularity. Number 3, an anastomosis which is without any tension. Number 4, a watertight anastomosis. Number 5, anastomosis with a free drainage. Number 6, redundoplasty if it is required, but that is not required in all the cases. However, if there is some extra pelvis, it needs to be excised, because it leads to stasis of urine, and that may lead to recurrent infections and formation of stones. So we are done with the posterior wall. We have taken 1 stitch at the corner. This stitch I take before placing the stent, because it is the corner, tight area, and there is a chance of taking the stent in that stitch. So if you take that stitch before placing the stent, so the chances of the stent being taken into stitch is quite low. So that we have done. Now the anterior wall will be done in the same manner. I prefer continuous suture. However, it is personal preferences of the operating surgeon whether you want to take interrupted sutures or continuous sutures. Some surgeons also advocate taking 2 or 3 or maybe 4 interrupted sutures near the corners, and doing the rest of the anastomosis with a continuous running suture. So it really matters, depends on the operating surgeon's preferences. However, the basic principles must remain the same. that is the vascularity especially is the most important factor here. I have not used any energy source while I was dissecting the ureter. You can see very clearly that the ureter is surrounded by its sheath. This sheath is holding the vessels which are running along the length of the ureter. Those vessels can be seen as well thanks to the magnified view. This vascularity really is important. One must not be denuding the ureter. Some people say that if you do not denude it enough, it is difficult to anastomose. On the contrary, I don't think that is really true. And the other important thing is that the area or the length of the ureter that needs to be mobilized must be enough to bring the ureter and the pelvis together, but that length should also be kept limited, because mobilization of more and more length of the ureter may also jeopardize its blood supply. This is the talk about the ureter. However, the pelvis needs to be mobilized fully, especially on the posterior wall, because if you don't mobilize the posterior wall of the pelvis, we are talking here about the laparoscopic pyeloplasty. So if you don't mobilize the posterior wall of the pelvis, it may be really difficult to bring the ureter and the pelvis together. Number one. Number two, the anastomosis will really be difficult if the posterior wall is attached to the surrounding tissue. So mobilization of the posterior wall of the renal pelvis is extremely important. So we have reached the corner. Care must be taken not to take the stent in the stitch. So after doing this, we can continuously run the suture up till the upper end of the cut pelvis. However, another strategy can be that we leave this suture here. We leave this suture here, and during the assessment, I thought that it may be really difficult to run this suture up till the upper end of the of our resection. So I left that suture here at the corner, and then I started with another suture. The advantage of this suture in this procedure to me was, number one, I knew exactly where the corner was, and number two, my assistant held this the tail end of this suture and lifted it up. So the anastomosis really was easy for me in the first part, and secondly, it was also here you can see that it is also helping me to see whether the stent is near or away, but you can see that it is really stretched, and the chances of taking the stent in the stitch is these chances are really slim with this maneuver, and it is more easy for me to take stitch from the posterior to the anterior wall at this location rather than taking from the anterior to the posterior wall, because in that case the IVC is near, the renal pedicle is near, so we are taking the needle and the tip of its needle away from the vasculature in the midline. So a little bit of area is just remaining here. And now we will see another advantage of this suture was that the suture coming from below and this suture from above, they are exactly on the opposite side to each other. So tying them together is going to help in the water tightness. So we'll keep the drain for 2 days or maybe 1 day, depending on the amount and content that it is draining. And usually I remove it on the 2nd day, but the catheter will remain for 1 week minimum, so that the pressure is reduced and is not transmitted to the anastomotic area, leading to leak. So we clean the area, and that's pyeloplasty. Thank you very much.